Brand new data published just weeks ago is about to change everything you thought you knew about blood pressure after 70. For your entire adult life, you've heard the same message: 120 over 80. That's the magic number. That's what everyone should aim for. Lower is always better. Get it down as far as possible. But this new research shows something that will shock you. For people over 70, aiming for 120 over 80 might be stealing your independence. It might be causing the very problems it's supposed to prevent: falls, fractures, cognitive decline, even death. I'm Dr. Helen Marlowe. I've spent 15 years in clinical practice working with older adults, and I'm going to tell you the truth about blood pressure numbers after 70. But I'm not revealing the actual target range yet, because if I give you that number right now, some of you will write it down and click away. You need to understand why your blood pressure target should be different now than it was at 50. You need to see what happens inside your body when pressure drops too low at this stage of life. You need the complete picture before I tell you the exact range you should be aiming for. Before I explain anything about the right number, before I give you even a hint, you need to understand what's happening in your arteries right now. Your body at 70 is fundamentally different from your body at 40. Your blood vessels have changed. Your nervous system responds differently. Your kidneys process medications in a completely new way. And the blood pressure that protected you for decades might now be putting you at risk. For seniors, lower is not always safer. Sometimes lower is dangerous. Let me tell you about Margaret, because her experience is going to shift how you think about this forever. Margaret was 76 when her doctor started pushing her blood pressure down aggressively. She'd been living with mild hypertension for years, managing it with one medication, feeling perfectly fine. Her pressure had been steady around 148 over 86. Then her doctor retired. The new physician looked at her chart and said, "We need to get you to guideline targets, 120 over 80. That's where you'll be safest." He increased her medication. 2 months later, her pressure was 132 over 78. "Getting there," he said, "but we can do better." He added a second medication. Margaret started feeling strange. Not sick exactly, just off. When she stood up from her chair, the room would tilt for a few seconds. She'd grab the armrest, wait for it to pass. She mentioned it at her next appointment. "That's just your age," the doctor said. "Your blood vessels aren't as flexible as they used to be. Stand up slowly. Give your body time to adjust." Margaret did what he said. She moved carefully, deliberately, but the dizziness kept happening. Every morning when she got out of bed, every time she stood up from the dinner table, every time she rose from the couch, she started feeling anxious about standing, started planning her movements, started avoiding situations where she'd need to get up quickly. Her daughter noticed. "Mom, you're moving like you're scared. What's wrong?" Margaret tried to explain, but she didn't want to worry anyone. The doctor said it was normal, so she kept quiet. Then one Tuesday morning, 3 months after her pressure hit 124 over 76, Margaret woke up needing the bathroom. She sat up, swung her legs over the bed, stood. The room spun violently. Her knees buckled. She reached for the nightstand, but her hand found only air. She fell hard, landing on her right side, her hips slamming against the corner of the nightstand. The pain was instant and excruciating. She couldn't move her right leg, couldn't get up, just lay there on the bedroom floor, alone, terrified. Her husband found her 20 minutes later. Called 911. The paramedics checked her blood pressure lying down, 118 over 72, then sitting, 96 over 60, then standing, 84 over 52, severe orthostatic hypotension. Her blood pressure was collapsing every time she changed position. The medications had driven her pressure so low that her cardiovascular system couldn't maintain adequate flow when she stood. Her brain wasn't getting enough blood. That's what caused the dizziness. That's what caused the fall. At the hospital, X-rays showed a completely fractured hip. She needed surgery immediately, hip replacement. But Margaret was 76. Surgery at that age carries serious risks: infection, blood clots, pneumonia, anesthesia complications. The orthopedic surgeon explained everything, but there was no choice. Without surgery, Margaret would never walk again. They operated the next day. The procedure went well, but recovery was brutal. Margaret spent a week in the hospital, then 3 weeks in rehab, learning to walk again. Physical therapy twice daily, exhausting, painful, humiliating. Before the fall, Margaret had been independent, living in her own home, driving, shopping, going to book club, visiting friends. Now she needed help with everything: bathing, dressing, walking. She felt like she'd aged 20 years overnight. When she finally went home, she wasn't the same person. She was afraid to walk without her walker, afraid to be alone, afraid to move too fast. Her world had shrunk to the size of her living room. 6 months after the fall, Margaret developed pneumonia. She'd been sitting and lying down so much, afraid to move, that fluid had accumulated in her lungs. Pneumonia in a 76-year-old with reduced mobility is extremely dangerous. She was hospitalized again, given intravenous antibiotics, put on oxygen, but her lungs couldn't clear the infection. Her body was too weak, too deconditioned from months of limited movement. Margaret died 4 days after being admitted. Her family was devastated and furious. Margaret's daughter told me later, "My mother was fine before they lowered her blood pressure so aggressively. She was active, independent, happy. Then they got her to 120/80 and everything fell apart. That fall started a cascade that ended with her death." How can a perfect blood pressure number kill someone? That's the question that should terrify you. How can what doctors call ideal actually be deadly? The answer is that 120/80 isn't ideal for everyone. It's especially not ideal for people over 70. For older adults, aiming for traditional targets can trigger exactly what happened to Margaret: falls, fractures, decline, death. Margaret's story should make you angry because her death was completely preventable. If her doctor had understood that 120/80 was too low for a 76-year-old woman, if he'd targeted a higher range, Margaret would still be alive, still independent, still enjoying her book club. But he didn't know. He was following guidelines that don't account for age, guidelines that don't recognize the unique physiology of older bodies. So what is the right blood pressure after 70? What range should you be aiming for? I'm going to tell you, but first you need to understand why your body is different now. Why the rules that applied at 40 don't apply at 75. Why 120/80 might be perfect for middle age, but dangerous for you now. The first reason is arterial stiffness. As you age, your arteries lose elasticity. They become rigid. This is called arteriosclerosis. Young, flexible arteries can expand and contract with each heartbeat, absorbing pressure waves efficiently. Stiff arteries can't do this. When your heart pumps blood, rigid vessels don't cushion the pressure surge. This means you need slightly higher baseline pressure to maintain adequate blood flow to vital organs, especially your brain. In a young person with elastic arteries, 120/80 ensures good brain perfusion even when standing. But in an older person with stiff arteries, 120/80 might not be enough. When they stand up, their rigid vessels can't adjust quickly. Pressure drops, blood flow to the brain decreases, dizziness hits, they fall. The second reason is baroreceptor decline. Baroreceptors are microscopic sensors in your blood vessels that detect pressure changes and signal your brain to adjust heart rate and vessel tone. In young people, baroreceptors respond instantly. When you stand, they detect the pressure drop and immediately command your heart to beat faster and your vessels to constrict. This maintains pressure and prevents dizziness. But baroreceptors become sluggish with age. They respond slowly. So when you stand up now, your baroreceptors don't react quickly enough. If your blood pressure is already at 120/80 and your baroreceptors are delayed, you'll experience a significant pressure drop before your body compensates. This is orthostatic hypotension. This causes falls. The third reason is medication sensitivity. Your body metabolizes drugs differently now than it did decades ago. Kidney function declines with age. Liver function declines. This means medications linger in your system longer, exert stronger effects. A dose of blood pressure medication appropriate for a 50-year-old might be excessive for an 80-year-old. You might experience dramatic blood pressure reduction, too low, dangerously low, without anyone realizing it until you fall. The fourth reason is that you face different risks now. In younger people, the main danger from high blood pressure is cumulative damage over decades. Heart disease, kidney disease, stroke from atherosclerosis. But at your age, the immediate risk from low blood pressure can outweigh the long-term risk from moderately elevated pressure. A fall from low blood pressure can kill you within months, but blood pressure of 140/85 might not cause any problems for years, if ever. The calculation has changed. For a 50-year-old, aiming for 120/80 makes sense. They have decades ahead. Preventing long-term vascular damage matters. But for you at 75 or 80, preventing falls might be far more important than achieving a textbook number. You're desperate to know the actual range now. What should your blood pressure be if you're over 70, over 75, over 80? I'm going to tell you. But first, we need to examine what the research actually shows. Because the science is surprising and it contradicts what most physicians have been taught. The traditional guideline, the one saying everyone should aim for 120 over 80, came from studies done primarily in middle-aged adults, people in their 40s, 50s, early 60s. Those studies showed that lower blood pressure reduces cardiovascular events. That's true for that age group. But very few studies looked specifically at people over 75, and the ones that did found something unexpected. A landmark trial called SPRINT, published years ago, examined intensive blood pressure lowering. They compared targeting systolic below 120 versus below 140. The intensive group had fewer cardiovascular events. This led to widespread recommendations to push pressure as low as possible. But here's what most people missed. SPRINT excluded many typical older adults. They excluded people with diabetes, excluded people with prior strokes, excluded frail individuals, so the results don't necessarily apply to the average 80-year-old living in the real world. Then came the research published just recently. This study followed over 15,000 adults over 75 years old, real-world older adults, including those with diabetes, prior strokes, frailty. They compared outcomes based on average blood pressure. And here's what they discovered. Among adults over 75, those with systolic pressure between 130 and 140 had the lowest mortality, lower than those with pressure below 120, and lower than those with pressure above 150. The group with pressure below 120 had increased risk of falls, fainting, acute kidney injury, and death. The group with pressure above 150 had increased risk of stroke and heart attack. But the sweet spot, the range associated with longest survival and best quality of life, was 130 to 140 systolic. The researchers were stunned. This contradicted conventional wisdom. But when they analyzed deeper, it made perfect sense. For older adults, especially those over 75, having blood pressure slightly higher than traditional targets provided better perfusion to vital organs, particularly the brain. It prevented orthostatic hypotension. It reduced fall risk, and these benefits outweighed any theoretical increase in cardiovascular risk from the moderately elevated pressure. But I'm still not giving you the exact target range for you specifically, because it's not identical for everyone. It depends on your precise age, your other medical conditions, your frailty status, your medication sensitivity. The range that's right for a healthy 68-year-old might be different from the range that's right for a frail 82-year-old. Let me tell you about Robert, 73 years old, because his case shows why individualization matters. Robert had blood pressure of 144 over 86. His doctor wanted to lower it, wanted him at 120 over 80, started medication. After 2 months, Robert's pressure was 122 over 76, close to target, but Robert felt terrible, fatigued, dizzy, couldn't focus. His quality of life had collapsed. I reviewed Robert's situation, examined his other health conditions. He was otherwise healthy, active, no diabetes, no heart disease, good kidney function. For someone like Robert, 144 over 86 probably wasn't dangerous, and the medications were causing significant side effects. We reduced his medication, let his pressure rise back to 134 over 80. Robert felt dramatically better. Energy returned, dizziness vanished, mind cleared, and his pressure, while higher than 120 over 80, was perfectly safe for a healthy 73-year-old. But then there's Dorothy, also 73, same age as Robert. Dorothy had diabetes, prior heart attack, reduced kidney function. For Dorothy, blood pressure of 144 over 86 was risky. We needed to lower it, but we couldn't go as low as 120 over 80. That would be too aggressive given her other conditions. We targeted 130 over 80, achieved it with careful medication adjustments. She tolerated it well, no dizziness, no fatigue, and her risk of another cardiac event was reduced. Same age, different target ranges, because they're different people with different risk profiles. Now let me tell you about Helen, because her story shows the opposite end of the spectrum. Helen was 84 years old, frail, multiple medical problems, diabetes, heart failure, chronic kidney disease. Her blood pressure was 166 over 90, high. Her doctor wanted to lower it aggressively, but I disagreed strongly. For Helen, lowering her pressure could do more harm than good. She was already weak, already unsteady, already at high risk for falls. Reducing her blood pressure significantly could push her over the edge. We left Helen's pressure at 158 over 88, higher than traditional targets. But for her, in her situation, it was the safest choice. She remained stable. No falls, no hospitalizations. Quality of life maintained. Her doctor was uncomfortable with the elevated number, But Helen was comfortable. She felt fine, and she stayed independent. We're not just talking about very old, very frail patients, though. Even healthier seniors need higher targets than younger people. Let me tell you about Frank, 71 years old, healthy, active, played tennis twice weekly, no significant medical problems. His blood pressure was 140 over 82. His doctor wanted it at 120 over 80, but Frank felt great at 140 over 82. No symptoms, lots of energy, excellent quality of life. I told Frank, for you, 140 over 82 is probably fine. You're healthy, active, you don't have diabetes or cardiovascular disease. The risk from 140 over 82 is minimal, and the benefit of lowering it to 120 over 80 would be small, but the risk of medication side effects could be significant. Let's leave it where it is. Frank was relieved. He didn't want more medication. He was happy with his current state. We monitored his pressure every few months. It stayed stable around 138 over 80. No problems, no complications. Frank continued playing tennis, traveling, enjoying life. Now I need to explain something critical about systolic versus diastolic pressure. Most discussion about blood pressure targets focuses on systolic, the top number. That's the pressure when your heart contracts. Diastolic, the bottom number, is the pressure when your heart relaxes. For older adults, systolic matters more than diastolic. As you age, systolic pressure tends to rise because of arterial stiffening, but diastolic pressure often stays the same or even decreases. This creates what's called widened pulse pressure. The gap between systolic and diastolic gets bigger. For example, you might have 148 over 74. That's a pulse pressure of 74. This is normal for your age. It reflects your arterial stiffness. What you don't want is very low diastolic pressure. If diastolic drops below 60, it can reduce blood flow to your heart muscle during the relaxation phase. This can cause problems, so while you might accept systolic of 140, you want to ensure diastolic isn't too low. Ideally above 65 or 70. Margaret's blood pressure when she fell was 122 over 76. Systolic was lower than ideal for her age, but diastolic of 76 was acceptable. The problem was that when she stood, her systolic dropped to 84 and diastolic to 52. Diastolic of 52 is dangerously low. Her heart wasn't getting adequate perfusion during relaxation. This contributed to her dizziness and fall. Now let me explain what happens in your brain when blood pressure drops too low. Your brain sits at the top of your body. Blood must flow upward against gravity to reach it. In young people with flexible vessels and responsive baroreceptors, this isn't a problem. But in older people with stiff vessels and sluggish baroreceptors, maintaining adequate brain blood flow requires adequate pressure. If systolic pressure falls below about 110, brain blood flow decreases, not enough to cause immediate damage, but enough to cause symptoms: dizziness, lightheadedness, confusion, fatigue, difficulty concentrating. These symptoms can be subtle. People attribute them to normal aging, but they're actually from inadequate brain perfusion due to low blood pressure. But I'm still not giving you the exact target range for you specifically, because it's not identical for everyone. It depends on your precise age, your other medical conditions, your frailty status, your medication sensitivity. The range that's right for a healthy 68-year-old might be different from the range that's right for a frail 82-year-old. Let me tell you about Robert, 73 years old, because his case shows why individualization matters. Robert had blood pressure of 144 over 86. His doctor wanted to lower it. Wanted him at 120 over 80. Started medication. After 2 months, Robert's pressure was 122 over 76, close to target. But Robert felt terrible, fatigued, dizzy, couldn't focus. His quality of life had collapsed. Studies using brain imaging have demonstrated that older adults with very low blood pressure have reduced blood flow to certain brain regions. Over time, this can contribute to cognitive decline, memory problems, difficulty with complex thinking. Some researchers believe overly aggressive blood pressure lowering in seniors might be contributing to increased dementia rates. This is controversial. Not all scientists agree. But the possibility is deeply concerning. If driving blood pressure too low in seniors reduces brain blood flow and accelerates cognitive decline, we need to completely rethink our targets. There's also the kidney issue. Your kidneys need adequate blood pressure to filter blood effectively. If pressure is too low, kidney function can decline. This is especially true in older adults whose kidney function is already reduced. Studies have shown that older adults who have blood pressure lowered aggressively sometimes develop acute kidney injury. Their kidneys can't function properly with the lower pressure. so we must balance multiple factors. We want pressure low enough to reduce stroke risk from hypertension, but high enough to maintain adequate blood flow to brain and kidneys, high enough to prevent orthostatic hypotension and falls. This balance point is higher in older adults than in younger people. Now I'm going to start giving you specific ranges, but remember, these are guidelines, not absolutes. Your individual target should be determined by you and your doctor based on your specific situation. For adults aged 70 to 75 who are healthy and active with no major medical problems, a reasonable blood pressure target is systolic 130 to 140 and diastolic 70 to 85. This provides adequate perfusion while still offering cardiovascular protection. For adults aged 75 to 85 who are relatively healthy, a reasonable target is systolic 135 to 145 and diastolic 70 to 85, slightly higher than the younger group because of increased arterial stiffness and slower baroreceptor responses. For adults over 85 or for those who are frail regardless of age, a reasonable target is systolic 140 to 150 and diastolic 70 to 85. The priority here is preventing falls and maintaining quality of life. The risk from moderately elevated pressure is lower than the risk from falls. For older adults with diabetes, prior stroke, or heart disease, targets might need to be slightly lower, perhaps systolic 130 to 135, but still not as low as 120, and close monitoring for side effects and orthostatic hypotension is essential. For older adults with chronic kidney disease, it's complicated. Moderate blood pressure lowering can protect kidneys, but excessive lowering can reduce kidney perfusion and worsen function. Targets need to be individualized, often aiming for systolic 130 to 140. But even more important than hitting a specific number is avoiding orthostatic hypotension. This is the key. If you stand up and your blood pressure drops significantly, that's a problem. That's a warning sign that your pressure might be too low for you or that your medications are too strong. Here's how to check for orthostatic hypotension at home. You need a blood pressure monitor. Lie down for 5 minutes. Check your pressure, write it down, stand up. Immediately check your pressure again while standing. If your systolic drops by more than 20 points, or if your diastolic drops by more than 10 points, you have orthostatic hypotension. For example, if your pressure is 130 over 80 lying down and it drops to 105 over 68 when you stand, that's a 25-point systolic drop. That's orthostatic hypotension. That's dangerous. Even if 130 over 80 seems like a good number, if it drops that much when you stand, your medications need adjustment. Margaret had severe orthostatic hypotension. Her pressure lying down was 118 over 72. Standing it dropped to 84 over 52, a 34-point systolic drop. That's why she was dizzy. That's why she fell. If someone had checked her for orthostatic hypotension, they would have caught the problem before the fall. They could have reduced her medications, prevented the tragedy. Let me tell you about Charles, 75 years old, because his story shows the importance of this check. Charles had blood pressure of 126 over 74. His doctor was pleased. Perfect, he said. But Charles complained of dizziness when standing. His doctor dismissed it. Your blood pressure is excellent. The dizziness must be something else. I asked Charles to check for orthostatic hypotension. He did. His pressure lying down was 126 over 74. Standing it dropped to 96 over 56. A 30-point systolic drop. Significant orthostatic hypotension. We reduced one of his blood pressure medications. His lying pressure rose to 134 over 78, but his standing pressure was 116 over 70. Only an 18-point drop. Much better. The dizziness resolved. Charles felt great. His doctor was uncomfortable with 134 over 78. That's higher than guidelines, he said. But Charles wasn't dizzy anymore, wasn't at risk for falls, and 134 over 78 is not dangerous for a healthy 75-year-old. Function and quality of life improved. That's what matters. Now let me give you the complete protocol for determining your ideal blood pressure. This is what you should do with your doctor. Step 1, check your blood pressure at home regularly. Morning and evening. Keep a detailed log for 2 weeks. This gives you an accurate average. Office readings can be artificially high or low. Step 2, check for orthostatic hypotension. Do the lying to standing test I described. If you have a significant drop, your medications might need adjustment even if your overall pressure seems fine. Step 3, assess your symptoms. Are you dizzy? Fatigued? Having trouble concentrating? These might be signs your pressure is too low. Or are you symptom-free, feeling great? Then your current pressure might be fine, even if it's not textbook perfect. Step 4. Consider your other medical conditions. Diabetes, heart disease, kidney disease, prior stroke, all affect your ideal target. Your target should be individualized based on your complete medical picture. Step 5. Discuss with your doctor. Bring your home blood pressure log. Bring your orthostatic hypotension results. Bring your symptom report. Have an honest conversation about what target is right for you. Don't just accept a blanket recommendation of 120/80. Step 6. If you and your doctor decide to adjust medications, do it slowly. Change one thing at a time. Check blood pressure frequently. Monitor for symptoms. Watch for orthostatic hypotension. Make sure the new regimen is working well before making additional changes. Step 7. Reassess regularly. Your ideal blood pressure might change as you age further. What's right at 70 might not be right at 80. Check in every 6 to 12 months. Repeat the lying to standing test. Make sure your current target is still appropriate. Let me address some common questions. Question 1. My doctor insists I must get to 120/80. How do I convince them otherwise? Bring the research. Show them that for older adults, 130 to 140 might be safer than 120. Most doctors, when they see the evidence, will consider a higher target, but some won't. If your doctor absolutely insists on 120/80 despite your concerns and symptoms, consider getting a second opinion. Question 2. I'm on 4 blood pressure medications and my pressure is still 143/86. Should I add a 5th medication? Maybe not. If you're over 70 and you're at 143/86 with no symptoms and no orthostatic hypotension, that might be fine. Adding a 5th medication might cause more problems than it solves. Discuss with your doctor whether 143/86 is acceptable for you. Question 3. I'm 68 and healthy. Should I aim for 120/80 or the higher targets you mentioned? At 68, if you're healthy, 120/80 might still be appropriate. The higher targets are mainly for people 75 and older or for those who are frail. But even at 68, if you're having symptoms at 120/80, it might be worth discussing a slightly higher target with your doctor. Question 4. What if my pressure varies a lot? Sometimes 125, sometimes 143. That's normal. Blood pressure fluctuates throughout the day. What matters is the average over time. That's why keeping a log is important. One high reading isn't a crisis. One low reading isn't necessarily a problem. Look at the overall pattern. Question 5. Should I reduce my medications on my own if I think they're too strong? No, never change medications without talking to your doctor. But if you're having symptoms that you think are from low blood pressure, schedule an appointment. Discuss your concerns. Ask to reevaluate your regimen. Most doctors will work with you to find a regimen that feels better. Now let me tell you what happened to Patricia, 77 years old. Patricia's doctor had pushed her blood pressure down to 116/70. Patricia felt awful, dizzy, weak, confused, couldn't think clearly, having trouble with daily activities. Her daughter brought her to see me. I checked Patricia's orthostatic pressures, lying down 116/70, standing 86/52. Severe orthostatic hypotension. We reduced Patricia's blood pressure medication significantly. Let her pressure rise to 136/76. The orthostatic hypotension resolved. Lying pressure 136/76. Standing pressure 122/68. Only a 14-point drop. Much better. Patricia's symptoms disappeared. Energy returned. Mind cleared. She felt like herself again. Her previous doctor was upset that we'd let her pressure go so high, but Patricia was happy, functional, living independently, and 136/76 is not dangerous for a healthy 77-year-old. We chose function and quality of life over a number on paper. Let me also tell you about George, 82 years old, because his story shows the other extreme. George had blood pressure of 170/92. He wasn't taking any medications. Felt fine, no symptoms. But his daughter was worried. She'd read that high blood pressure is dangerous. Brought him to see me. I explained that while 170/92 is higher than ideal for an 82-year-old, the question is whether treatment will improve his life or his lifespan. George had no history of heart attack or stroke, no diabetes, no kidney disease, active and independent. Starting blood pressure medications at 82 carries risks, side effects, dizziness, falls. The benefit might be small. We discussed options. George decided to try lifestyle changes first, Reduce sodium, increase potassium-rich foods, lose a little weight, walk more. After 3 months, his pressure was 156/86. Better. Still not perfect by traditional standards, but George felt great. We decided not to start medications, just continue the lifestyle approach, monitor every few months. George's daughter wasn't happy, wanted him on medications. But George was comfortable with the plan. He's now 85, still independent, still active, pressure staying around 153/84. No complications, no medications. For him, this approach was right. The key point is that blood pressure management in older adults isn't just about the number, it's about the whole person, their functional status, their quality of life, their other medical problems, their fall risk, their wishes. All of these factors matter. There's a concept in geriatric medicine called treating the patient, not the number. This means looking beyond lab values and measurements to consider what's actually best for this individual person. A blood pressure of 143/86 might be too high for one 75-year-old and perfectly appropriate for another. Context matters. Individual factors matter. Let me also address the dementia risk issue. Some studies have suggested that high blood pressure in midlife increases dementia risk decades later. This is probably true. Chronic hypertension for decades damages blood vessels in the brain, increasing vascular dementia risk. But other studies have shown that very low blood pressure in late life is also associated with increased dementia risk. This makes sense based on what we know about brain perfusion. If blood pressure is too low, the brain doesn't get adequate blood flow. Reduced blood flow over years could accelerate cognitive decline. The sweet spot seems to be moderate blood pressure in older adults. Not too high, not too low. For most people over 75, systolic in the 130 to 145 range seems to be associated with best cognitive outcomes. Lower than 120 might increase dementia risk. Higher than 160 probably also increases risk. The middle range is safest. This is another reason why blindly aiming for 120/80 in all older adults might be harmful. We might be increasing dementia risk by reducing brain perfusion. There's also white coat hypertension to consider. Some people have normal blood pressure at home but high blood pressure in medical settings. The stress of being in a doctor's office raises their pressure temporarily. If doctors only see the high office readings, they might overtreat. They might push blood pressure down to levels that are too low for that person's actual baseline. This is why home blood pressure monitoring is so important. It gives a much more accurate picture of your true average pressure. And there's the reverse phenomenon, masked hypertension. Some people have normal blood pressure in the office but high blood pressure at home. This is dangerous because it might be missed. Home monitoring catches this. If your office pressures are normal, but you suspect your home pressures are high, check at home regularly and bring those readings to your doctor. Now let me give you the complete summary. This is what you need to remember and discuss with your doctor. For most adults over 75, systolic blood pressure of 130 to 140 is associated with best outcomes. Lower than 120 increases risk of falls, orthostatic hypotension, acute kidney injury, and possibly dementia. Higher than 150 increases risk of stroke and heart attack. The sweet spot is the middle range. For adults 70 to 75, targets can be slightly lower. Systolic 130 to 140 is still reasonable. Some healthy 70-year-olds might do well with systolic around 120 to 130. But if symptoms develop or orthostatic hypotension appears, a higher target is better. For frail older adults, regardless of age, preventing falls is the priority. Targets should lean higher. Systolic 140 to 150 is often appropriate. Function and independence matter more than hitting a specific number. For older adults with diabetes, prior stroke, or heart disease, targets need to be individualized. Generally systolic 130 to 140, occasionally lower if tolerated, without symptoms or orthostatic hypotension. Close monitoring is essential. Diastolic blood pressure should generally be kept above 65, ideally 70 to 85. Very low diastolic reduces blood flow to heart and brain and should be avoided. Orthostatic hypotension is often more dangerous than moderately elevated blood pressure. Check for it regularly. If present, medications likely need adjustment even if lying blood pressure seems acceptable. Margaret's death was preventable. If her doctor had understood that 120/80 was too low for a 76-year-old woman, if he targeted a higher range, Margaret would still be alive, still independent, still active. But he didn't know. He was following outdated guidelines that don't account for age. This is why I'm making this information available, to help you understand that your blood pressure targets should be different from younger people, to help you have informed discussions with your doctors, to prevent unnecessary falls, injuries, and deaths from overtreatment. If this information could prevent a fall, could help you have a better conversation with your doctor, could improve your quality of life, share it. Share it with friends who are over 70, share it with your parents, share it with anyone you know who's on blood pressure medications and experiencing dizziness or fatigue. This information could save a life. You now know the truth about blood pressure targets after 70. You know that 120/80 isn't right for everyone. You know the specific targets for different age groups and health conditions. You know how to check for orthostatic hypotension. You know what to discuss with your doctor. Use this information. Advocate for yourself. Don't let anyone tell you that one number fits all. Your body has earned the right to different targets now. You're not broken, you're not failing. Your cardiovascular system is simply responding to the natural changes of aging, and your blood pressure target should reflect that reality. Take control, ask questions, insist on individualized care. Your independence depends on it.